I'm Dr. Sotiria Palioura.
Hi, I'm Dr. Nubile and welcome to the first episode of this two-part independent medical education video interview on the ocular surface disease. We'll start with the data that tell us about what the surgeons and the clinicians usually do when they look at the patients, and we will focus on one of the most common conditions, which is meibomian gland dysfunction.
Mario, here is a teaching slide from the 2024 ESCRS Clinical Trends Surveys. And the question was, do you systematically check the ocular surface in all your preoperative examinations? And only 61% of the respondents, as you can see here, they said yes. And just 55% said yes for cataract patients.
These data are really important. And since the prevalence is really high, this means that we're going to lose a lot of data on patients who really suffer from whatever condition affecting the ocular surface disease, especially pre-operative.
I think we really have to integrate it into a workflow. The same way we're used to check vision and pressure in every patient, we have to be checking the ocular surface in every cataract surgery evaluation, preoperative evaluation.
So you mean this should be part of our logical workflow, like when we look at the slit lamp and we check if the cornea or the crystalline lens is transparent, look at the ocular surface, look at the meibomian gland, something like this that should be integrated part of our checking system.
Exactly.
Another important question, so why this matter to us surgeons?
So we know that ocular surface disease or dry eye disease, there's a spectrum, and on one side we have severe aqueous deficiency, usually of autoimmune etiology. On the other side, we have severe evaporative dry eye from meibomian gland dysfunction. But most of our patients, especially in the cataract population, will be somewhere in between, usually with an evaporative component contributing more into the surface disease.
As an example, I would say many patients may be asymptomatic before cataract surgery or whatever kind of anterior segment surgery. We should include also refractive surgery. But then after the surgery, they become, surprisingly for them, symptomatic, and they attribute everything to the surgery, which is probably not the case. And what it changed is that if you explain to the patient that they still suffer from a condition affecting the ocular surface health, and you pre-treat them, then it's good because probably your postoperative outcome will be better, so they will not complain that much for postoperative induced symptoms after cataract surgery. But also you reach the target that they are informed that they have a somehow kind of unstable condition, and if something happens, something gets worse, if they get some postoperative symptoms, they are prepared to understand that it's part of the entire surgical process.
So patient education and preoperative counseling are a must.
For sure.
Yeah. So once we understand the impact, the next step is figuring out exactly what we're dealing with. That means a thorough and efficient workup in our clinics. So for ocular surface disease in general, what does your clinic workflow looks like?
First of all, I would say that even if we have a variety of very technological examinations, which are good because you can pick up a lot of things regarding the ocular surface, usually you don't need to spend always money and time as far as you use one drop of fluorescein and regularly test the ocular surface health with your slit lamp at the beginning. You check, of course, the status of the meibomian gland, which can be just simply integrated part of your slit lamp examination. It takes 30 seconds, no more, and you have a clear idea of the condition of the ocular surface. Here, breakup time can be done electronically, non-invasive way, which is really nice because you can document, you can show to the patient what they have. But also I would assess the symptoms, which are the symptoms, if they are there, that bother their condition during their daily life. Because this is something that is always misunderstood by the patient and by the clinician, so take your time to interview the patient.
I think just being cognizant that I have to look at all the patients and I look at them in a systematic way. So I always start with the lids and lashes, I will ask them to look down and take a good look at their meibomian glands on both upper and lower eyelid. I will look at the puncta, and then I agree with you that instilling fluorescein, and we have to instill just a little bit of it because otherwise it just blurs everything, so you can see subtle details. Oftentimes you have ocular surface disease that causes subtle epithelial basement membrane lines on the surface, and if you don't see that, then you may be implanting the wrong lens for a patient because your keratometry will be changing or the surface will be very aberrated, and you may choose a lens, a premium or a simultaneous vision lens that also creates aberration, and that could be a problem afterwards. I do rely a lot on topography, so I like to have a regular map, and if I have 2 visits on the same patient, I always make sure that that map hasn't changed. And I have available in my practice epithelial thickness mapping, so I also like to look at that. And actually, if I see an irregularity in that map, I will go back and re-examine the patient if I haven't noticed something, just to make sure I understand why it is irregular.
It is very important to understand that if the ocular surface is altered, also the optical quality of our eyes is significantly modified by the status of the tear film, and therefore, especially patients who are seeking for premium lenses or multifocal lenses, they be not so satisfied, and they could express the reason to the lens, but somehow the reason is reliant on the brain, of course, but also on the ocular surface.
Absolutely.
If you diagnose really a true meibomian gland dysfunction, then you have to focus exactly on the gland status and what is happening there, and you need to try to improve the status of the gland. So it's just not a simple, mechanism just replacing the tears and give some eye drops or lubricants, because this might not be sufficient if you don't treat the underlying cause of the disease. So you need to study the status of the lacrimogram. So try to do, if you can, meibomography, or try to treat this with warm compressors, try to do expression on the meibomian gland. So as soon as you get a better cleanser, lid hygiene, all these methodology are really helpful, but not if you do just once a week or once a month or as a trial, but you have to instruct the patient to do it constantly.
So I think that patient education, I can't stress that enough, then patient counseling preoperative is a must. The patient needs to understand that once they have ocular surface disease, this is a chronic issue and it cannot be fixed by just instilling a drop. So they have to have a routine at home, and given that most of our patients, especially our cataract patients, will have evaporative dry eye due to meibomian gland disease, they have to make part of the routine at home lid hygiene, lid cleansing, and using tears, not when they are symptomatic, but to prevent symptoms. And if you educate them on that the reason they're doing it is to prevent symptoms and to also prepare the surface of the eye for surgery, and because they're going to have a better outcome, and it's not really treating the surface, it's not really delaying the surgery, it's actually about their safety and a better outcome after the surgery. For mild disease, I will just do lid hygiene and tears. For moderate disease, I will consider adding an immunomodulator like cyclosporine or a mild steroid. If there's a component of rosacea with lid margin telangiectasias, I will add oral doxycycline, and I will start considering in-office treatments like thermal pulsation or IPL. And if I have a severe disease, I know I need to delay my surgery further. And if there is a significant aqueous deficient component, I even will start them on serum tears.
Do you also consider screening of this patient for rheumatological assessment if you suspect that there is something underlying there?
Absolutely, yes. So if I see staining on the cornea, and especially if I see it on the conjunctiva as well, because fluorescein doesn't only stain the cornea, it only stains the conjunctiva when the eye is very dry. So in those patients, I will always recommend a rheumatologic evaluation.
I think it's an important key point.
Yeah.
So thank you everybody for joining us for this first episode of the EuCornea meta-independent education video interview series focused on ocular surface disease.